I have the pleasure of introducing Niraj Kothari, who's one of our newbies in the faculty in nephrology. He's been here a couple of years. He's from Kansas, hails from Kansas, and is an avid some kind of Chiefs fan or something like that, some football team out there. I don't know much about them. But anyway, he's from Kansas. He did his medical school, University of Missouri, followed by a residency at St. Louis University Medical Center, and then went to Duke to do his nephrology training. And from Duke, he came here as first an instructor for a year, and now as an assistant professor in our division. He's has lots of interest in informatics and such things like that. And he's teaches me how to do Zoom. Actually did that, when we first started, since I was worthless doing it. And so he's very much involved with the IT part of medicine. He's the medical director of our ambulatory clinic, and is also one of the medical directors of one of our outpatient dialysis facilities in Tappahannock. So I welcome Niraj. He's going to talk about health disparities in CKD and end-stage renal disease and the effects of the COVID-19 pandemic. So thank you, Niraj.
Thank you. And Dr. Geer, thank you so much for the kind introduction, and to everyone listening, thank you all for the warm welcome today. Let me share my screen. Okay. So I have no relevant disclosures, but it's a pleasure to be here, and thank you all again for welcoming me. Over the course of this talk, I hope that you will gain a perspective of existing disparities affecting the care of patients with both chronic kidney disease and end-stage kidney disease. I hope that you'll be able to understand the potential and observed impacts of the COVID pandemic on disparities affecting the care of these patients. And I hope that we'll be able to have a brief discussion of strategies to mitigate disparities affecting the care of these patients, especially in light of this unprecedented healthcare crisis in the world. So first, what disparities do kidney patients face? And I'm always drawn to this quote by Dr. King: of all the forms of inequality, injustice in health is the most shocking and the most inhuman. So we see disparities leading to worsening outcomes and increased costs for disadvantaged populations. And the population of patients with kidney disease already suffers from substantial disparities in care. They're already suffering from these issues. And during the COVID pandemic, I think that rapport and trust building between patients and their caregivers is particularly critical, when everything from masks to vaccines to everything else is politically charged and controversial. It's hard to figure out what to believe and who to believe. And we need that trusting relationship with our patients more than ever. But the presence of disparities, both in the past, the present, and the future, even if not directly related to healthcare, is something that I would argue affects this dynamic. As disadvantaged populations often already have lower trust in the healthcare system, they look at protests and they see that one population is being told, we will dominate you, and another population is being told, we love you. And so I think it would be only natural that one's faith in other so-called power positions, such as that of medicine, could be shaken as a result. And another issue is that we just don't have enough data on these disparities. So over the course of this talk, I'll present the data that I was able to find, but we need more. There are several disparities for which I really don't think there's good data at all, particularly for kidney patients. So one example of that would be LGBT groups. Another example would be South Asians in the United States. And one could go on, but I think the point is we need to understand more clearly what our citizens, what our patients are dealing with. The other issue is that some of the data we have is based on outdated concepts. So for example, we see race now as a social construct, and perhaps many in the audience would say it always has been, and I would agree, but many of the data we have reference it explicitly. And so I've included these data because for now, it's what we have. But I think that we as a medical community are going to need to discuss how to use these data to minimize these disparities and not to exacerbate them. So chronic kidney disease and end-stage kidney disease represent a tremendous burden to the public healthcare system in this country. This is a huge and vulnerable population. About 15% of adults in this country have either chronic kidney disease or end-stage kidney disease. And we spend a lot on it. This is just what Medicare spends on kidney disease. This doesn't count private insurance, this doesn't count Medicaid, this doesn't count self-pay. And as you can see, just for chronic kidney disease, we spend over $81 billion. Just for end-stage kidney disease, we spend close to $50 billion. And so when we add it up, we spend more than $130 billion just from Medicare on kidney disease. And when we compare that to what may seem like other large budgets, like that of NASA at $20 billion, the NIH at $37 billion, or all graduate medical education funding at $15 billion, I think it's pretty clear that if we're able to bend the curve of this spending, we could accomplish many other great things. Perhaps we could give all of our residents a raise. We could give Dr. Fauci a raise. We could invest more in scientific development to benefit our country. But right now, chronic kidney disease is not distributed equally. So these are data from the US Renal Data System for 2020. And what this graph is showing is the rate or the prevalence of chronic kidney disease for adults under the age of 65 in yellow and over the age of 65 in orange. And so as one might expect, there is a substantially higher prevalence of moderate to advanced chronic kidney disease in adults over the age of 65. Now, as you may be aware, age is part of our eGFR calculations. And so with increasing age, the eGFR estimate goes down. Even if creatinine, for example, remains stable, then one's presumed stage of chronic kidney disease would go up. So this is perhaps an expected disparity. I don't think just the calculation accounts for all of it. But when we talk about access to care, I think this disparity becomes much more relevant in the COVID era. There are also disparities in prevalence of chronic kidney disease between genders. So this graph is showing the difference in prevalence of chronic kidney disease from about 2003 to about 2018. And most recently, women have been shown to have about 20% higher prevalence of chronic kidney disease than men. Now, as you can see from this graph, this disparity has actually narrowed from about 30% in the 2003 to 2006 period. This isn't because women are doing any better, but because men are doing worse. So I wouldn't call this a true elimination of disparity. We want everyone to get better, but want to make sure that we are benefiting everyone equally. There are some caveats to this. If GFR is not adjusted for body surface area, that may underestimate GFR in women. Women tend to have longer life expectancies, so there may be more of them to have chronic kidney disease. And not shown on the graph, but men actually end up progressing through the stages of chronic kidney disease more rapidly than women. But I think this point, and I'll touch on this more throughout the talk, is that there are significant gender disparities with chronic kidney disease. There are also significant disparities with regards to poverty and education, as one might expect. So for patients living in poverty, these patients suffer from 17.4% prevalence of chronic kidney disease versus just about 14% for those who are not in poverty. The disparity is even more stark when we look at education. Close to 20%, close to 1 in 5 patients who are not high school graduates have chronic kidney disease, compared to just about 13% of patients with at least some college education. So chronic kidney disease has higher prevalence in disadvantaged and uneducated cohorts. There are significant race-based disparities in chronic kidney disease progression. So again, race is a social construct, but for now, these are the data we have. So these are, again, US Renal Data System data showing information for Medicare beneficiaries 66 years of age or older. So the yellow shows stage 3, The orange shows stage 4, the green shows stage 5 as a percentage probability of chronic kidney disease progression. And so as we can see, there are substantially higher rates of progression in non-white cohorts for CKD stages 3, 4, and 5. And so I think a critical question is why? And as one might expect then, this leads to an unequal distribution of end-stage kidney disease. So again, USRDS data, what is being shown here is the adjusted prevalence of end-stage kidney disease by ethnic background or by race. And so the red line is for Black patients. The gray line is for American Indian or Alaska Native patients. Green is for Asian patients, and blue is for white patients. And these are cases as a proportion of the population. So when we talk about 500,000 people in the United States being on dialysis, and we look at the relative rates for population, it's very clear that Black patients are disproportionately and tremendously so being hit by end-stage kidney disease. This is a tremendous disparity in our population, looking at the numbers as a percentage of population for our Black patients, our Native American patients, and our Asian patients. And again, the question is, why? And part of it is the duration and the ability of these patients to access nephrology care before starting dialysis. So these are data for incident end-stage kidney patients. What percentage of each cohort saw a nephrologist before needing to start dialysis, and for how long? So in yellow, we have the category of 0 to 6 months. That means that they did see someone, but just for that period of time. In orange, 6 to 12 months, and in green, 12 months or more. There are other categories from these data for none and unknown. I've left those out for the sake of clarity, but as you can see from the graph, Black patients were again less likely to have received any pre-dialysis nephrology care, just 63%, compared to white and Asian patients at about 70% each. And as one might expect, lower access to nephrology care before dialysis is associated with higher rates of tunneled hemodialysis catheter use. For the non-nephrologists in the group, we don't like these. We prefer arteriovenous fistulas and grafts. These tunneled catheters have significant risks of infection and overall poor outcomes. What was interesting to me was that there was actually a similar duration of pre-dialysis nephrology care between genders, and actually looked a little bit better in older age groups. And I'll show that on the next slide. So these again are data for incident end-stage kidney disease patients. So again, what percentage of each cohort saw a nephrologist previously? And so what we can see here is that patients in the age groups of 65 to 74 and 75 and over actually had a little bit better rate of access to nephrology care, with the worst group being patients between the ages of 18 and 44. And I suspect that part of this is because this population, 65 and up, has access to Medicare. They can access physician or other provider care more easily than people in the younger group who may not have access to health insurance. And when we find that patients have unequal access to nephrology care, we can then see that these patients have unequal and dissimilar transitions to dialysis. So as we all know, we would prefer that our patients start dialysis out of the hospital. For the non-nephrologists in the group, the ideal way is that the patient starts to feel uremic symptoms. They already have an access because they're following with a nephrologist. We get the proper labs to rule out hepatitis B, hepatitis C, and tuberculosis. We refer them to a dialysis unit, and they start there without ever having to come to the hospital. But as you can see from this graph, for any group of patients listed, the rates of this out-of-hospital transition are pretty poor compared to crashing into dialysis. So on the left in yellow, we have the relative rates for white patients, Black patients, and other races. As we can see, there's a significant difference in the rates of transitioning to end-stage kidney disease. And on the right in blue, we have the relative rates based on age. So as we can see, our patients who are in the older age categories, again, have much higher rates of hospital-based transitions to dialysis. Now, from the age standpoint, there could be other reasons for this. Our older patients may have more comorbidities, they may be less stable, they may have initially decided not to do dialysis and then have changed their minds. But overall, I think we can all agree, one, overall, we don't transition enough patients to dialysis outside of the hospital, and two, several populations are being hit by this disproportionately. Another disparity is an uneven distribution of outcomes after acute kidney injury. So these graphs are showing rates of death in green, chronic kidney disease maintenance or stable kidney function in blue, chronic kidney disease progression in red, and end-stage kidney disease in gray. And so for patients with pre-existing chronic kidney disease who were hospitalized with acute kidney injury, this graph shows what happened to them over time. And as we can see, over time, these disparities widen so that Black patients and patients of other races have significantly higher rates of progression to end-stage kidney disease or just progression of their chronic kidney disease, even in a relatively short period of time. These disparities are present, but not as widely so in patients who did not have chronic kidney disease prior to being hospitalized with ACAC, but they are still present. So whether or not a patient has chronic kidney disease, non-white race is associated with poorer outcomes after hospitalization. So this is showing uneven distribution of outcomes after acute kidney injury based on age. So on the top left, we have patients between the ages of 66 and 69, top right, 70 to 74, bottom left, 75 to 84, and bottom right, 85 and over. So as one would expect, the rates of death are much higher with older age. These patients are older, they are sicker, they have more comorbidities, they may be more likely to pursue non-dialysis care options. But I would argue that there are some data that aren't being captured. How many patients who have progression of chronic kidney disease to end-stage kidney disease are directly going to symptomatic only management and passing away rather than starting dialysis? So even though we would expect some increased rates of death in older populations, I don't think that's the entire picture, and I think there's more to be learned about what is causing these disparate outcomes. When we talk about people who have progressed to end-stage kidney disease, it's also clear that these treatments are not created equally and they are not distributed equally. As you may be aware, as nephrologists and as society, we would prefer that our patients not utilize in-center hemodialysis. There are executive orders from the top requesting and incentivizing nephrologists to start patients on home dialysis and to encourage patients to pursue kidney transplant. And what we can see from these data is that the rates of in-center hemodialysis versus the preferred treatments for end-stage kidney disease are quite disparate between races. And so we can see that the rates of home dialysis and preemptive transplant, our preferred options, are much higher in our white populations and our Asian populations compared to, say, our Black and African American populations. And does that mean that we want to stop offering it to the populations who have higher rates? Absolutely not. Of course, we want everyone to increase use of home dialysis and preemptive transplant. But I think it underscores the point that we need to put a little extra effort in and understand why these other groups are not being able to access the preferred modalities at the same rate. One other area of disparity is location. As one might expect, there are higher rates of home dialysis uptake in rural communities. And so this map is showing the geographic distribution of home dialysis use. The darker red areas indicate higher use. Overall, excuse me, home dialysis is used for about 11% of dialysis patients or home dialysis patients. but again, higher uptake in the rural populations. But when we compare that to the distribution of nephrologists, who are predominantly concentrated in urban and suburban areas, I would argue that many of these patients are underserved by nephrologists. So perhaps that isn't surprising. We all know that rural patients as a whole are generally underserved in terms of medical care. But this issue of rural patients using more home dialysis and the nephrologists being concentrated in urban areas does cause issues. It impairs access to care for rural home dialysis patients. We talk about 11% of rural patients on home dialysis compared to about 9% of urban patients. Yet peritoneal dialysis is available in only 36% of rural counties compared to about half of urban counties. Home hemodialysis is available in only 17% of rural counties compared to 24% of urban counties. And another study is showing that, unsurprisingly, because of this, rural patients have to drive further to get dialysis care. And so in the first column on the left, we see the distance to dialysis units for urban patients, only about 4 to 7 miles. Compare that to rural patients who have to drive anywhere between 18 to 36 miles to get to their dialysis unit. So the patients who are using home dialysis the most are having the hardest time to get care. And as one might expect, this leads to problems when we look at their outcomes. So this table is showing the long-term mortality risk over 90 days, stratified by distance from the dialysis unit. And so we can see significantly higher rates of mortality, both for hemodialysis, but more strikingly for peritoneal dialysis. And this may be because peritoneal dialysis patients in rural areas may be choosing this modality out of necessity rather than through choice. They may not have an Incenter dialysis unit available to them close by. Rural hospitals may have fewer subspecialists available. There may be poorer outcomes with their hospitals if they are unable to access the care or equipment that they need. And so this is showing that the patients who are traveling furthest have the highest mortality rates. And one potential solution to this may be telemedicine, but as I'll get to in the next section, this has problems of its own. So what is happening in the COVID pandemic? And what does this mean for kidney patients? And as one might expect, there are quite a few issues. So I'm sure everyone saw the article from JAMA in 2018 ranking the complexity of patients by each subspecialty. And perhaps I'm a little biased, but of course I agree, nephrologists were at #1. And whether or not we agree with this, whether or not the data was collected correctly, the point I want to make is that this is an incredibly complex patient population, particularly in the setting of this pandemic. There are data to suggest substantial delays in transplantation, particularly in the spring of 2020, as we were entering our first major wave of COVID infection. I have not seen data yet for our current wave, but I suspect there may be issues again. As one might expect, it's causing issues with follow-up care. It will lead to issues initiating dialysis as an outpatient. If a patient can't see their nephrologist or can't talk to their nephrologist, then if they feel sick, they have to go to the emergency department. These patients have increased risks of adverse outcomes from COVID-19 infection. And I think perhaps underappreciated is the effect of transportation on this population, particularly the in-center hemodialysis patients who are often dependent on public transit or dedicated medical transport. And I'm sure everyone who lives in the city of Richmond is aware, our GRTC is doing the very best they can, but they have a lot of drivers who are infected with COVID. They are restricting, as a result, the number of buses they offer. And so these buses are more crowded. So these patients who are using public transit have impaired access to transportation. Some medical vans will either refuse to accept COVID positive patients or have inadequate separation. And so in my own personal experience, I've had several situations where one patient going to the dialysis unit tests positive for COVID. There are maybe 1 or 2 other patients in the van with them. They are then exposed and they have to quarantine as well. There are significant gender disparities, as I touched on a little bit earlier in the talk. So we already discussed a higher prevalence of chronic kidney disease in women. As we're all aware, women constitute a disproportionately large proportion of formal and informal caregivers. And in the United States, 65% of unpaid family caregivers are women. 33% of jobs held by women are defined as essential versus 28% for men. I would say here, though, these statistics do not count educators, and women are 3/4 of K through 12 teachers. And so really, the share of essential jobs held by women is even higher. This graphic on the right is showing the percentage of female representation in certain occupations, mostly those that are seen in the hospital, such as speech language pathologists, dental assistants, social workers, physical therapists, and pharmacists. And unfortunately, women spend more time in unpaid work. They spend about 4 hours a day versus 2.5 hours a day for men. And these data predate the COVID pandemic. And so when we talk about the burdens now of dealing with homeschooling and other childcare, unfortunately, we already have data to suggest these burdens are again falling disproportionately on women. I don't know how many of you saw the great New York Times article a few months ago that mom's Zoom meeting is the one that has to wait. Even in dual career households, both mom and dad are working, still it's mom's career that is getting put on hold unfairly and frankly unacceptably. And so as one might expect, even though it's horrifying, I suspect not entirely surprising, that 79% of healthcare workers infected with COVID are women. So when we talk about access to care, when we talk about prevalence to care and women having a higher prevalence of chronic kidney disease, and now I would argue shouldering a greater burden during the COVID-19 pandemic, I think that this is going to exacerbate a pre-existing disparity for these patients. Another population that's suffering from this would be undocumented immigrants. Even before COVID, they had significant barriers to accessing follow-up care for chronic kidney disease, and they had substantial barriers to dialysis because many states do not provide Medicaid funding for outpatient dialysis for these undocumented immigrants. So they end up having to go to the ER, usually twice or 3 times a week, in order to obtain emergency-only dialysis. As one might expect, this significantly increases costs. It's thought that an undocumented immigrant requiring emergency dialysis accounts for about $400,000 a year in healthcare spending versus a patient with chronic outpatient hemodialysis costing about $70,000 to $90,000 per year. This increased cost to our healthcare system. This increases burden on our emergency departments and overall utilization of our healthcare and hospital resources, in addition to the poorer outcomes for these populations. And again, transportation issues play a role. We saw this graphic earlier in the talk, but I wanted to come back to it. So this was the graph showing the growing disparity of outcomes with time for patients with chronic kidney disease who were hospitalized with AKI. And the reason I brought it back is because we have been dealing with COVID for about 11 months at this point, I would say. And these data show that even at 11 months, there are differences in these outcomes and significant differences. And it's going to be an even bigger issue moving forward. In a study from New York, patients who were Black had a significantly higher rate of AKI in COVID infection, about 23% higher than white patients. And so what this means, when we already understand that for, say, Medicare beneficiaries over 65, Black patients have 50% more AKI as a proportion of their population, we see that, for example, Black patients are getting hit with more COVID, they're getting hit with more AKI in general, and they're getting hit with more AKI in the setting of COVID, and yet these outcomes for them are worse. And so it's a snowball effect of all of these disparities adding together and causing substantially worsened outcomes for these patients. When we talk about dialysis, again, COVID has not affected these patients equally. So this is looking at the rate of COVID-related hospitalizations by epidemiologic week, and this is roughly correlated with calendar week. And as we can see from these data, the rates of hospitalization for COVID among dialysis patients were substantially higher for Black patients, about twice as many in the spring. Now, this is actually narrowing over time, though again, we don't have data for the current surge. And actually, compared to the general population, where Black patients are 3.7 times more likely to be hospitalized with COVID than other patients, the dialysis population is actually doing better, but this is still very bad. When we look at this by dialysis modality, again, as one might expect, there is a disparity in COVID-related hospitalizations because in-center hemodialysis patients have to come to the dialysis center 3 times a week. They're exposed to a healthcare environment far more frequently than peritoneal dialysis patients who often need to come to their dialysis center only once a month. And with the pre-existing rollout of telemedicine, even before COVID, for these home dialysis patients, often just 1 in 3 months. A correlation does not equal causation. The other thing I will clarify is that the hemodialysis graph here does not separate home hemodialysis from in-center hemodialysis patients. But when we've looked at the disparities in access and use of home dialysis compared to in-center dialysis, I would argue that the other disparities with access to nephrology care, access and utilization of home dialysis, again create a snowball effect leading to differences in COVID-related outcomes as well. So what is happening to our in-center dialysis patients? They need to come back to the dialysis center 3 times a week. Transportation, as we mentioned, is tough. They're often sharing rides. They're often using public transit, both of which are more difficult for COVID-infected patients. As we can see from this picture, this is a typical dialysis unit. So one can argue, yes, they are probably 6 feet apart or more, but this doesn't account for the staff who are continuously needing to walk around the room to check on patients, to adjust the machine. This is not accounting for other patients who may be walking past to get to their own chair. And so even though the chairs themselves are separated, it would be difficult for me to say that the patients themselves are separated at all times. These patients often have impaired access to other healthcare resources and other medical care, and the COVID isolation protocols are particularly difficult for them. Here in Richmond, looking at several of the groups here, several of the dialysis companies here, when a patient is infected with COVID, they are sent to one particular dialysis unit, which for my dialysis patients is about 20 miles away from my center. And if they are PUIs, they are sent to yet another dialysis unit, which is about 10 or 15 miles away from my own home unit. And so do I agree with the need to isolate COVID positive and COVID PUI patients? Yes, but I think we need to be mindful of what that means for our patients who are already facing difficult access to transportation and what it means for them to have to travel 20 miles to their dialysis unit instead of 2 miles, and what that means in terms of how well they're able to catch a bus or get a cab or get a Medicaid or Medicare provided van. These challenges, again, are often not shared by the home dialysis population. Now, what about outpatient care overall? What about clinic visits? Now, these are data showing overall outpatient visits, not just nephrology. And again, we don't have data for the current wave, but as we can see, there was a significant change in cumulative visits during the spring. And I am concerned that we may see a similar drop, though hopefully not as severe, during our current surge of COVID patients. So when we talk about pre-dialysis nephrology care being so critical, with this kind of drop, there are a lot of patients who are unfortunately going to fall through the cracks. One other study I had seen showed about 1/3 of hospitalized COVID patients developing AKI. So we need more follow-up to be available, but our patients are less able to get it. So one potential solution is telemedicine. And what about it? As mentioned, I am helping the nephrology department with the rollout of telemedicine. And I've had a lot of great support from elsewhere in the internal medicine department, from Dr. Geer and Dr. Mishra. But overall, as we all know, the utilization of telemedicine has increased significantly, including here at VCU. And there are potential benefits to this. Our patients are not exposed to the healthcare environment. They don't have to worry about transportation. They can bring in multiple family members from different locations. They can bring in a son from Florida and a daughter from California, right in the room with them to talk about their disease. But there are significant disparities in access to and utilization of telemedicine. And this existed prior to the pandemic. And I'm concerned that increased reliance on telemedicine, while I think overall a positive, may exacerbate these existing disparities. Another issue is that particularly for nephrology, but for many other fields as well, our patients are very complex and we have to engage in very difficult conversations. I frequently have patients referred to my clinic who are already in stage 5 of chronic kidney disease. And so as one might imagine, that's a very difficult conversation in the best of times with the patient in front of me, me holding their hand and looking into their eyes and talking to them about what it means to be on dialysis and talking to them about what it means to get a kidney transplant. When we're talking about meeting a patient for the first time and having to have this very difficult and life-altering conversation over a phone call or over a Zoom meeting, and the need for strong rapport and mutual trust in this conversation, I think it underscores the point that this is going to be much more difficult, even if necessary, to deal with this pandemic. As we can see in the nephrology population, we are relying substantially more on telemedicine. So this was a survey from the Renal Physicians Association, just asking nephrologists what percentage of one's non-dialysis chronic kidney disease patients were receiving kidney care via telehealth. And I thought it was really interesting that over 60% of the respondents indicated that more than 75% of their patients were getting their nephrology care through telemedicine. But again, there are disparities in the willingness to use telemedicine. So these data are from a study conducted by the RAND Corporation, who surveyed about 2,500 adults about their willingness to use telemedicine to communicate with a physician to get advice about a health issue. So if they have a question, what do you think about my blood pressure? What is happening with my orthostatic dizziness? Things like that would be counted. However, other requests such as appointment requests or medication refills were not included. And so the table on the right is showing odds ratios for several selected groups and their willingness to use telemedicine. So again, Black race, patients over the age of 65, and patients with less education were all substantially less likely to use telemedicine or less willing to use telemedicine. But willingness is not the entire story. What about the ability to use telemedicine? What about the ability to access telemedicine? So one option is to use a smartphone. And indeed, smartphone use is relatively high in the United States, but this may not be enough. Many patients are reliant on smartphones only for their data connection. And as one might expect, there are disparities in terms of their access. Maybe patients have very limited data. Maybe they're on a prepaid plan, or maybe they don't have a smartphone at all. The other issue is that even if a patient has a smartphone, do they understand how to use it? And we've been seeing increased rollout of more patient-friendly telehealth options. I think Doximity is one. Zoom, I think, is improving. But we need to make sure that our patients actually understand how to use this technology. Another issue is that not all patients can access our video visits at all. Now, we can expect that there would be generally higher patient understanding of what's discussed in a healthcare visit, patient satisfaction of a healthcare visit when we're using a video visit, perhaps Zoom or Doximity, compared to a telephone encounter. But there are several barriers to using video-based telemedicine. One is age. Adults over the age of 65 have only about 55 to 60% smartphone or broadband access. Another is income. There are lower rates of smartphone ownership. And of the people who have smartphones, lower income individuals are more likely to use this as their primary internet connection. Rural patients have poor access to internet connections. Often the connections are slower, often they're less reliable. And again, racial and ethnic minorities often face barriers to accessing these modalities as well. The public health emergency status that was introduced because of COVID has allowed telephone visits to be reimbursed at the same rate as video visits, where previously they weren't reimbursed at all. Now, VCU itself has done a wonderful job of trying to accept all patients regardless of the modality. We all prefer to do video visits. We like to do video visits, but it's a great boon to our patients that when they have difficulty coming to the hospital or when it's a risk for them to come to the hospital, but they don't have access to telemedicine visits, we at VCU are able to offer them telephone visits, even if we don't prefer to. But when we look at, say, private practices, this reimbursement parity becomes much more critical because right now we have this parity, but this emergency status will not last forever. I'm sure you all saw that the Secretary of Health and Human Services has extended the duration of this public health emergency, but there will come a time when it's lifted. And the question is, will we still be dealing with the residual effects of this pandemic? Will our patients still need these telemedicine services? And if so, will we be able to provide our services to them via telemedicine? So we've talked about a few potential barriers, but what is actually happening? And unfortunately, what is actually happening is that vulnerable populations are being affected as a result of the COVID pandemic. So this is a paper from UCSF looking at their primary care visits. Unfortunately, I wasn't able to find these data for nephrology, but these data were comparing the proportion of each population in ambulatory visits prior to the COVID-related telemedicine ramp up to after that ramp up. So compared February to late March of 2020. UCSF saw an increase of video and telephone visits combined from about 3% of ambulatory encounters to 96%, nearly all of their encounters. But as we can see in the orange bars, there were significant drops of the proportions of visits by groups that one may consider to be disadvantaged. Our Black patients, our African-American patients, Latinx patients, older patients, patients for whom English is not a primary language, and patients on Medicare and Medicaid. So again, not for nephrology and not accounting for the current wave of COVID infections, but I think this shows very clearly that the patients about whom we're worrying the most, for whom we're seeing issues with accessing care, our fears are unfortunately coming true that these patients are having trouble getting the care that they need. And so the question is, what do we do about this? What can we do about this? And I think the first thing is that we need to acknowledge that disparities in delivery of healthcare are real. Now, many of these disparities and inequities are structural, and we are going to need a lot of buy-in from society at large, not just within the world of healthcare professionals. But the first step is for us to acknowledge that these disparities and inequities and biases are present. We need to remove barriers in healthcare to delivery of telemedicine care. We need to make sure that our support staff know how to use these technologies and know how to assist our patients so that our care providers are not having to deal with a limited time slot to see a patient and spending half the time, as I frequently do or did, trying to walk patients through how to set up Zoom or how to set up Doximity. Again, I think VCU itself has done a really great job in terms of encouraging staff, in terms of offering training to our support staff and our partners in the healthcare system to help optimize this workflow. But I think in the healthcare system of the United States as a whole, we have a lot of work to do. And a lot of this is going to be policy changes. And so I hope that we can all advocate for the encouragement of broadband and smartphone adoption in our population. Because of the CARES Act, the Federal Communications Commission was able to throw in about $200 million to enhance access to telemedicine for underserved populations. But when we talk about the other numbers we're throwing around, I think we need a lot more to help ensure that all of our patients who need telemedicine can access it. But it isn't just about having the access, it's understanding how to use it. And so I think we need to help ensure that our patients understand how to use these technologies. They have the tools and the resources they need to really use these platforms effectively. And we need continued reimbursement parity. We're relatively fortunate here at VCU to be protected from many of these effects, but when we talk about other healthcare systems or many doctors in private practice who may not enjoy those same protections, we really need to make sure that this is a system-wide change so that all patients can access these modalities. But we also need to think about ourselves as individuals. I think teamwork is critical, but a team is made up of a lot of individual efforts working for the benefit of our team and of our society and of our patients as a whole. And so we all try and do this, but I think it's important to reiterate, we need to have empathy for these difficult conversations and understand that perhaps talking to a patient about initiating dialysis is a lot harder over the phone when we're meeting for the first time, when we can't look them in the eyes or hold their hand or give them a tissue when they have tears in their eyes. We need to have extra empathy for these conversations we're having, and we need to have extra understanding when there are problems when we're using these technologies. Maybe Zoom goes down, maybe the patient's data connection isn't great, maybe we're having trouble hearing each other. We need to have that extra understanding that problems may occur, and that comes from both ways. We need to understand that on behalf of our patients, and I hope our patients understand that for us, that as healthcare professionals, we are also doing the very best we can with our situation. Many of us are working hard to care for COVID patients or more patients in general. And so extra understanding on the part of all people that we're all human beings, we're all in this together is going to be critical. So in summary, there are significant disparities impacting care delivery for patients with chronic kidney disease and end-stage kidney disease patients, particularly those from disadvantaged communities. And I'm sorry about my typo. The COVID-19 pandemic has the potential to exacerbate these disparities, though we need more data on the true impact. But this pandemic and the effects of this pandemic are rapidly evolving. So I would argue that we can't necessarily wait for data. We need to be proactive, and we need to start taking all the steps we can to mitigate the impact of the pandemic on disadvantaged populations. So with that, I want to end. There are a lot of people I want to thank, particularly my division chief, Dr. Todd Geer, and the chief of telemedicine here at VCU, Dr. Vimal Mishra. They have both been incredibly supportive of me, both as I've been learning about telemedicine and as we've all been working to roll out telemedicine, particularly in the division of nephrology. So I want to thank them both by name. I also want to thank the entire division of nephrology here at VCU. They've also been fantastically supportive of me as a new faculty member and as we've been rolling out telemedicine. I do want to clarify, this photograph was taken pre-COVID. That's why we aren't wearing masks. And I want to thank everyone in the Division of Medicine or the Department of Internal Medicine here at VCU. I really appreciate the warm welcome I've received here, both as a new faculty member and inviting me to speak here today. And I thank you all for letting me take a little bit of your Thursday afternoon. So take care, stay safe. I'll be happy to take any questions that you have. All right, looks like that's everything.